Thank you to our speakers. Those were really wonderful talks. So next up, we actually have some case presentations for our panelists, but also we're going to be polling the audience. If we can bring up those slides. Great. Okay. No disclosures. Stare at that slide. Okay, so for case number 1, we have a very large female with a BMI 47 who presented with purulent peritonitis secondary to diverticulitis. There's pus throughout the abdomen, and you're worried about creating a colorectal anastomosis. So this question is actually first for our audience. Who would be so worried about creating an ostomy in through this patient's abdominal wall that they would create a primary anastomosis and avoid diversion? Yeah. Okay, great. Who would be very worried about bringing up an end colostomy through this patient's abdominal wall and consider possibly an end loop? Okay, and so anyway, we can now just move to our panelists. So how are you proceeding and what would you do? A end colostomy and just drag that mesentery edge through the abdominal wall? Would you do an end loop? Would you mobilize the splenic flexure to really do your best trying to pull up that colostomy? Or would you just close your eyes, put them together, and like pray that you never have to go back in there again? We can start from Tom if you want to.
To the first question of what am I worried about, all the
things
I'm worried about, they're all bad. But I think for me, probably in a patient like that, I'd roll the dice with the colostomy. I think it is, notwithstanding the data to support primary anastomosis and diversion, I never want to go back in while they're sick. So I would probably choose that, but all the options are undesirable.
Yeah, I would second that. I'd much rather deal with a stable patient with a very large peristomal hernia. I'm going to mobilize everything I can, bring it up as high as I can, somewhere under the ribs where abdominal wall is going to be a little thinner. Gravity is not our friend. And make a big hole, bring it up, and then deal with the hernia down the line.
Yeah, I agree. If we go ahead and make the anastomosis, and if something happens to that, then that's just a scenario that could potentially jeopardize the patient's life. So I would try my best to, if we have to mobilize, then we have to mobilize, try to make the stoma.
Yeah, I mean, I agree with all the above. Part of me wants to default into resecting anastomosis and a diverting loop ileostomy, but taking down the diverting loop ileostomy would not be awesome either. So I guess, I agree. I wouldn't go to the operating room with I'm 100% going to give this patient a colostomy, because of these factors. But depending on how sick they are and how things look inside, I think if I'm not comfortable letting the anastomosis ride, I think a very high upper left, Palmer's point type of colostomy is going to be our safest option.
I would agree with all of that. I mean, I would definitely think about it because you have to go through all the options at this point of what's the best for the patient. You have to consider the patient's hemodynamic status in the operating room. But sometimes just trying to bring up nothing's going to be ideal. So at this point, might as well go with what's kind of best for the patient in the long run, and maybe, advise the patient that there's a high chance that this might be a permanent stoma in the end. But at the same time, it avoids further surgery and it might get her out of the operating room quicker.
Go ahead.
It almost seems to me that you would always do a colostomy even if the patient was skinnier. That was one statement. And the next statement is, are you diverting routinely if you do a nasty appendicitis with pus all over the place? And the answer is probably going to be no. So why would you do a different treatment here just because she's obese? I mean, if you find two ends that look great, there's no reason not to put it back together and maybe do a more proximal diverting ileostomy. If you go a little bit high on the ileostomy, she's going to nicely lose weight.
I think that brings it back to the question early on brought up by Dr. Curran about on-table lavage. And in my mind, it really depends on how much stool there is in that colon. We must not have any friends at our institution because we actually do it in certain circumstances, especially when the patients have like bad stercal colitis and have a colon that's just loaded with solid stool. So your point is well taken. Randomized trial for that, I think, is going to be a while, right?
Go ahead. Nigel Francis, thank you for this amazing discussion. I think the question here about whether to join or not to join is not related to the BMI. Let's clarify that. Is related to how stable the hemodynamic status. And as you recall, the guidelines which we're updating the EAS SAGES guidelines for diverticulitis, if the patient on NORAD or any inotropes prior to ventilation, because they will all crash immediately under GA and they will all require metreminol and all of that. No, prior to intubation, if they've been on inotropes, you don't join them up. And that's the guidelines, and you bring a stoma. And I think most of us hopefully would agree with that.
Okay, thank you.
Can I just make a comment?
Oh, please.
You also only have to mature the colostomy to the fascia. You can always bring the skin down. With colostomies and stool, it's a little more acceptable to have the skin exposed. So if you can get it just to the fascia, cut out some fat, you can always bring your skin down and almost have like a funnel for your colostomy. And that'll give you 6 or 7 centimeters in a morbidly obese patient.
Thank you for that. When I'm fashioning these colostomies, I think it's all about the mesentery. So I get really concerned about not pulling the mesentery all the way up to almost at the skin level for sure, because I think that is the source of retraction, and really worry about that. So I will do everything I can and make a huge hole if I have to make sure that actually that mesenteric edge is able to be pulled up, and I do have more luck with an end loop. So I may go all the way to the transverse colon, and someone who is just so difficult, that descending colon is just sucked down so deep. So for these types of patients, when they're so challenging, I'll go up and I will bite the bullet for reconnection later, taking out so much more of that colon if you have to. But that mesentery just has to be higher up, and you just have to do everything you can, because that retraction, especially early post-op, it can be really critical for those patients and can get quite sick. But thank you for your comment. So for case 2, we have a 38-year-old male. He's taken to the operating room for presumed perforated diverticulitis. I think this can happen, unfortunately, quite commonly as younger patients are being diagnosed. We perform a partial sigmoid colectomy. We debride this abscess. We created end colostomy. The final path, though, comes back as T4 adenocarcinoma with 3 out of 6 lymph nodes positive for cancer. Okay. So in your office, when you're discussing this path with your patient and maybe on your tumor board, this will be a poll for the audience. Anyone is starting chemotherapy right away? Would anyone do an upfront reoperation first? Okay. And then before reversal, this is going to be now for our panelists. Before reversal of the colostomy, what are you doing? Are you going to do a laparoscopy to take a look around? Are you going to do any sort of scopes like endoscopy through the colostomy and through the rectum? And then I'm assuming everyone's getting CAT scans. So what do you guys want to do?
For this type of situation, I think the chemotherapy is really the critical thing, and if their colostomy is functioning, I think that getting them through the treatment is going to be critical. To prepare for the restoration of continuity, generally I'll do a FlexSig and a CT abdomen pelvis with IV and rectal contrast to define the anatomy and make sure that there are no occult strictures or things that would interfere with the anastomosis, and then typically start with usually the whole case minimally invasive frequently, but make sure there's no carcinomatosis or anything unexpected.
Yeah. I think to add to that, I would actually add time. I would not take this patient right after chemotherapy. I would sometimes push them out for as long as a year out to make sure we don't manifest something somewhere else. And again, chemotherapy is going to be most important. But another thing that I would potentially consider is, in this case, doing a PET scan to see if something lights up anywhere that can help you with planning.
Before the reversal, I usually do full colonoscopy, especially if he's 38 and probably never had a colonoscopy before. So I would do a scope fully through the colostomy and also through the anus for the rectal stump. I would also get a CT scan with the rectal contrast. If this was his only surgery and he didn't have any other abdominal surgeries before, I would usually try to do it minimally invasive first.
Yeah, I agree with all the above. I would probably get genetic testing as well. That may change my operation that I do for the final, hopefully final go around on him.
I don't really have much to add, being the fifth person in line here. But I agree with all of the above. I was going to mention colonoscopy as well. That's pretty much it.
Okay. And then at the time of operation, what would be your plan? And Andrea, we could start.
Okay. So I tend to also wait. I think the treatment for his cancer really has to take priority here. And assuming that he's gone through everything, tolerated the chemotherapy, is feeling well, I would go ahead and plan for a minimally invasive approach first. I find that I've been surprised in the past. Some of these cases you read, even the OR note, and you kind of expect the worst, and then you put in a camera and you're pleasantly surprised that you can go ahead and do everything, and you're going to obviously end up mobilizing flexure at this point to prepare for anastomosis, which is so much better, minimally invasive. Incisions are smaller, so that's my first approach. And I mean, I'm realistic. If I'm struggling and it's really taking a lot of time, at least the patient's consented prior to surgery for conversion to laparotomy.
Yeah, completely agree.
Oftentimes, what I would actually do with these folks, I anecdotally, it's about 50%, but I think you can finish it minimally invasively. What I do, I actually would start taking down their colostomy first, because then I can staple it off, try to keep it reasonably clean, and it gives me a window into an abdomen. I can put an Alexis and take a look, and then I'll know right away, instead of trying to enter somewhere else, wherever I can finish it or not, and I just use it as one of the port sites.
Is anyone thinking about getting Surg-Onc on board, or like looking first just to be worried, like in case there's any sort of small like peritoneal disease, or thinking about HIPEC in these settings?
We are not typical HIPECers for colon cancer. I think we'll do it for, I get that they're young, they've been treated. I feel like we are not routinely doing HIPEC for colon cancer at our institution. The data's just not there yet.
Yeah, I think the data on that is not really great. We do some of it for kind of a limited disease, but this is where like a PET scan and then looking, and yeah, I would have a discussion with the patient ahead of time saying, if I'm seeing kind of too much and it's not gonna, then we're gonna back out. But our surgical oncologists, if they do it, they will not plan for it kind of upfront. They definitely will insist on laparoscopy first.
I think for those type of things, if I find any carcinomatosis or peritoneal disease that I'm not expecting, both in this circumstance and in general, I think best to just keep your operation minimally invasive, assess peritoneal carcinomatosis index, a way of quantifying the burden of disease, close, and then you don't burn any bridges for down the road. You can refer them on for consideration of typically some degree of systemic treatment, and then you could consider HIPEC in select patients.
But you're still doing the anastomosis.
I wouldn't do the reversal at all. I think if I found carcinomatosis, I would just assess the disease burden, stop, and I wouldn't want to burn any bridges for them.
I think during the first operation, the mesenteric dissection was not done well. I would definitely go after the pedicle and take it at the runoff of the aorta in the second operation.
Yeah, agree. Okay. So for case number 3, we have a 47-year-old male who presented with a large bowel obstruction, and there you see this apple core lesion in the sigmoid. In the first setting, we have a patient who has multiple liver lesions that are consistent with metastasis. So in the audience, who is who is taking this patient for a sigmoid resection? Is anyone stenting this patient with distant metastasis? Great, okay. So in a different setting, this patient has this large bowel obstruction secondary to this apple core lesion here. However, there's no evidence of distant disease, so we have a locally advanced but resectable sigmoid cancer. Is anyone doing a stent in this patient? Okay. And then is anyone doing a resection? Okay. All right, so we can start at the end again, Andrea, if you want to say what you would be doing for a patient with stage 4 with a large bowel obstruction. Are you stenting at your institution?
So we do have stenting at our institution. However, we're very selective with who we stent. The gastroenterologists are not keen, unless it's in a palliative care setting, to go ahead with the stent. Young male, presumably healthy, with unfortunately multiple liver lesions. Once, complete staging, if they're completely obstructed, I think the first thing would be for surgical resection, and then after to discuss this patient at multidisciplinary tumor board, depending on where the lesions are located, refer them to a hepatobiliary. But the goal here is to get them to chemotherapy, really. So relieve the obstruction because they won't be able to get chemo. And what I have seen, though, is that I think stent, in order to abridge for surgery, in order to prepare for a primary anastomosis, is also acceptable. But I know that where I am, they won't accept to do that. So those are the two scenarios.
So is anyone so for the second setting, in a case where it's a obstructing cancer, but there's no evidence of distant disease, is anyone comfortable stenting those patients?
Yeah,
Yeah, why not?
yeah, we do it.
I would hesitate more with the metastatic disease because they're going to get Avastin and there's a very high stent perforation instance with, it's happened to at least 3 of ours in the past 5 years. It got stented, they got Avastin, and then we were like, why did we do that? But if you're going to resect, local regional disease without distant mets, is the only reason you're stenting so you can bowel prep? Or I guess I'm just trying to, I would want to know what we're gaining by stenting if it's something that you would upfront resect anyway.
Well, if the patient has
Like acute bowel obstruction.
has a huge bowel loaded with stool,
So it's to
right?
be able to put them
As a bridge to stenting, I think there's pretty good literature that it's a useful tool.
I think that stenting is a valid option for both number 1 and 2, but for number 1, I think diversion is another good option rather than resection. And for number 2, I think stenting does decrease bowel edema and make the subsequent surgery easier. So, as long as the patient can have good follow-up and plan for an elective operation within, say, 2 to 4 weeks after stenting, I think it's a reasonable choice.
Great. I do think that, and given the literature, people are much more comfortable stenting in the setting of distant metastasis than something that doesn't have any distant disease because of the risk of perforation, and you're causing something that is like a local problem and turning it into a perforated cancer. So there is that risk. And so some institutions and some surgeons may be less comfortable with stenting when there's only localized disease. So but yeah, appreciate that. And then in terms of like locations, and we did mention this, I think during one of your talks, was just the location of the tumor. So really any tumor in the rectum is really challenging to stent. The patients get a lot of problems with symptoms related to it, and also it really can decrease their distant margin, basically. So because you have to, when you place that stent and you have that stent that's going to be several centimeters lower than that distal margin already, you're kind of compromising, taking more of that distal rectum. So, and then other places that we know are a little bit tricky for intervention or endoscopists to stent are going to be the flexures too, just to keep in mind. We do have one more case. How's our time? Okay. So one more case. We have a patient that basically had a history of metastatic cecal cancer with liver metastasis and was currently on FOLFOX. At initial staging, the CT scan did show an intussusception of the ileum and cecum into the ascending colon, but at that time, the medical oncologist thought the patient was asymptomatic and so proceeded with chemotherapy. So if that medical oncologist did call you and say, hey, look at the scan before I start chemo, what do you think? In terms of the audience, is anyone saying proceed with chemotherapy first? And if the patient is asymptomatic with probably not this particular CT scan, but so an asymptomatic intussusception of a known colon cancer, is anyone proceeding with liver mets? Anyone proceeding with chemo first? Okay, and then anyone going straight to surgery and then doing adjuvant chemo? Okay. So in this case, I was not consulted. So the patient showed up to the emergency room with mild distension and moderate tenderness and a scan that did look like this, also already having received chemotherapy for a couple cycles. So for the panel, what operation are you doing for this patient? Oh, on chemo, and the counts were normal.
So I think actually one of the studies that Dr. Curran mentioned was a Foxtrot trial, and a very important part of it is that when they did a neoadjuvant chemotherapy and then took these folks straight to surgery, like within a couple of weeks, with chances of complications, including leaks and superficial and deep space infection, were actually very low. So I'm not worried about FOLFOX. I would resect and I would probably anastomose unless I run into technical issues or bowel is really abnormal. It will delay their continuation of a chemotherapy, but I think I would probably put them together.
I think for me, probably, just as Dr. Poilin said, my plan a priori would probably be primary anastomosis, but I would keep a very low threshold to make an ileostomy here, just because their lifeline is contingent on continuing their chemotherapy for the liver metastasis. So if they were malnourished, for example, or had other risk factors for leak, I would probably default to an ileostomy for them.
Any other questions from the audience at all about any of the cases or the presentations?
Could I just ask the panelists a question about the very first case? Many of the panelists actually just resect the colon, wash the patient out, send them to ICU or whatever, and then bring them back in a couple of days just to avoid all the issues with having to do a stoma and all.
So I guess I probably would not, because I think it does take at least a couple of weeks for that colon that's going to be not just distended, but this is chronically distended, very edematous, to get back to normal. A couple of days is, at least anecdotally for me, is not long enough to then feel comfortable about putting them back together. And, you know, if I'm going to do that and I'm going to do an on-table lavage, then I'll give them diverting loop ileostomy at that point, and then take it down later.
I agree. At the index operation, I would be quite minimalist in this diverticulitis case and almost resect only the diverticular segment, bring up the colostomy as best I can, and then basically set the stage where the planes in the pelvis in particular have not been disturbed for the reoperation. I would not, I don't think, consider a interval same admission restoration.
I know where that question comes from. We did this topic in a journal club, and there are multiple studies that support what you're suggesting is working. So I don't think it's I don't think it's a bad idea, and I do think that there have been multiple studies proving that that's a safe thing to do. I just don't think that has yet made it into our practice, and certainly in this patient, you know, our biggest thing is hopefully how do we never have to go back in that abdomen again, intubate that person again, all the things that go with a BMI of 47. I think that's a big part of our reluctance, but I definitely I know that there's literature out there to support your suggestion.
Okay. Well, thank you everyone for the audience participation and to our panelists for a wonderful session. Appreciate it all. Thank you.